You ready? I am Julia Schwiffiger. I'm the Vice President of the Illinois Physical Therapy Association, and I am delighted, no talking about sex until the speaker. I am delighted to announce Sarah Haag, who is talking about It's All About Sex, which is a topic that I think is very important, and having run a lot of different teams of therapists, seeing them struggle or giggle or not want to address or not feel capable of addressing things that are uncomfortable, including sex, but not limited to. I just want to thank you and thank all of you for coming, and those of you on the web. And with that, I'm going to turn it over to Sarah. I hope I'm not causing that.
No, you're fine. She did such a lovely job of introducing myself. I don't feel the need to say much more about me. But we are going to talk about sex and some potentially awkward other subjects. I would like to just ask the people in the room, though, I would like to know what kind of settings we have. Who's in outpatient general stuff? Excellent. Any home health? No home health. Inpatient? Acute stuff? Neuro stuff? Okay. What do other people do? Okay, so
I'm in peds.
Okay, peds. We have a good peds. Peds matters too, but it's not going to apply so much today.
You'd be surprised what I teach them.
There we go. I'm really happy to see a gent here. Well, a student here.
The title brought me in.
I told Colleen, you put sex in the title.
Yeah, how can you refuse that?
There we go. But I figured that, so we're going to put that at the sex bit at the end, just so it stays. So here's a question: as PTs, why on earth would we want to even talk about this stuff? One, it's bowel and bladder function, sexual function, very important to our everyday lives on many different levels, varying degrees. I feel like there's some weird feedback to something. Is that me?
Somebody needs to mute themselves who's calling in.
Can everyone mute themselves? That sounds weird. Okay, cool. So changes in bowel and bladder function are signs of things that need to be looked at by a medical professional of some kind. This isn't just stuff that we ignore. Changes in sexual function can actually indicate issues with cardiovascular health in men. And it's obvious, but it still needs to be said, bowel and bladder function can really impact your quality of life. If you can't leave the house because you're scared you're going to have a bowel movement unexpectedly, that's a huge impact on what you're able to do socially, physically, everything. And assuming that patients we're working with who are ill or disabled don't care or aren't interested in sex, it's really unfair, and it's quite frankly wrong. It's part of the whole person. All right, so why should we do this? So we're PTs, we're working on our mobility. Why should we be the ones doing this? We have the time. In most cases, we're spending more time with our patients than any other medical practitioner. We get to know them a little bit more. They start to open up a little bit more, and they're going to start mentioning things to you that they've maybe not told anyone else. Most patients don't share these issues with doctors because a lot of doctors don't ask about them. So if you're coming in for your annual exam, annual checkup, and maybe you started to leak urine a little bit, if the doctor doesn't ask you about that, what are the odds you're going to say, "Doc, I know you have 4 minutes with me, but this is going on." If it's a big problem, you might. A lot of people just carry on. And finally, we can be that helpful person who can make the appropriate referral. People don't ask for help sometimes because they don't know there's help. So if they learn from you that there is, in fact, help for them, they're going to be more likely to ask for help. And then certainly if they're like, okay, great, there's help, where do I go? We have a wonderful network of people, some pelvic PTs, but also physicians and other counselors who can really help out with that issue. All right, so quick note on asking awkward questions. It's only as awkward as you make it. So if you're going to be asking a question, there should be some underlying reason why you're doing it, some information you'd like to get. There's nothing awkward about it. And this was actually from Callie Rosenbaum, who spoke for us on sexual dysfunction at CSN earlier this year. It's just if you ask with kindness and respect, people don't get offended. So, I mean, don't go like, hey, are you peeing your pants? There's ways to ask, kindly, respectfully, and you're likely going to get good information. Okay, so we're going to start with some common misconceptions about urinary incontinence. A lot of people think it's normal to leak after you've had a baby. It's normal to laugh or cough and leak urine. A lot of people think it's just a normal part of aging. It's not. And finally, the fact that it's so common, and there are some studies that say over 65% of women and 45% of men are experiencing some degree of urinary issue. Just because it's that common doesn't mean that it's normal. And I think a lot of times all the commercials for products that can just deal with it for you have actually fed into that, oh, it's normal, I don't need to do anything about it. And so yeah. So what's normal? Who knows what normal is? How many?
6 to 7 voids per day.
Now how about overnight?
Give that man.
I'll go with none. Go 1.
0 to 1 for kids. Well, for kids, people under 65. 65 and over, 1 to 2. So how many people have had a patient go, God, I'm tired because I was up 14 times going to the bathroom? Or who have asked you for the 3rd time during the treatment session, I'm really sorry, but I've got to go again. These are things that are not normal. So what is normal? Being dry is actually normal. I'm not sure when we decided that being wet is okay for a normal, but really being dry is in fact normal. Okay, so some possible causes. So if you know the cause of what's going on, it's going to be that much easier to find the right way to address it. Childbirth is in fact one of those things that can really challenge the pelvic floor of a female, and that could be a cause. It doesn't mean that it can't be helped. A lot of people don't realize C-sections, 12 months post-op, have just as high a rate of incontinence as women who deliver vaginally. So some people think, oh, we totally missed the pelvic floor with the C-section. Doesn't mean issues can't arise later. Urinary frequency and urgency, we're going to talk a little bit more in a minute. But having that frequency and urgency, if you don't get there in time, you have incontinence. Urgency and frequency and overactive bladder could kind of be considered in the same bucket. However, overactive bladder is really when the detrusor starts to be a bit on the twitchy side and you're actually getting like some good bladder contractions. Having frequency and urgency can sometimes almost result in the overactive bladder. Poor bladder habits, one is the going just in case. So if you go to the bathroom, if anyone's had a puppy or maybe even a child, they kind of want to go out, you let them out, they go pee. The more you let them out, the more they're asking to go out. It's the same thing with our bladder in a lot of ways. So if you're going just in case and you don't really need to go, you're going to start getting that signal earlier and more often and more strongly as time goes on. Also, holding it forever and ever and ever is not very healthy. It's not so much that you're going to damage anything, but really it's messing up that normal cycle of fill, stretch, tells you to go, you empty, and you start over. Pelvic floor dysfunction is really, it's a broad term. Basically, our pelvic floors should contract, relax, and they should be coordinated to help us stay continent, support our core, all of these things. So having dysfunction, it could be weakness, and a lot of people assume if you're incontinent, that's what it is. Not the case. We call it a short, tight pelvic floor, a non-relaxing pelvic floor can also result in incontinence. And these are actually where I think PTs forget. People can have incontinence because of poor mobility. So just the time and effort from when they feel they need to go, of getting up out of the chair, getting to the bathroom, managing clothes, and finally being able to empty the bladder can take just too long. So that's something, no matter what kind of situation you're practicing in, we can have a huge impact, especially if you know that's a problem for them. And then poor hand dexterity. Sometimes their mobility getting to the bathroom is okay. Managing maybe a buckle, maybe buttons, those are times where maybe you can help them figure out some ways around it. Maybe they need an OT referral. But those are things that have nothing to do with the pelvis. You don't even have to go there. It's just a matter of helping them find the right answer. Okay, causes of increased frequency and urgency. So this is, again, a person who's telling you 3 times in a session, I've got to go again. It is possible they have a UTI. That would obviously need to be addressed medically. Stuff like diabetes, even very early pregnancy. People are like, no, I'm not pregnant, or I'm just barely pregnant. How can it be impacting my bladder? Those hormones make things crazy. So early pregnancy, prostate issues. So not so much like prostatitis issues, but more just that normal enlargement of the prostate over time can give that urgency and frequency. Medication. So a lot of people who end up in PT are on medications of some kinds. Diuretics and the timing of those medications can make a huge impact as far as how frequent and how urgently they need to go. Bladder cancer, I like to put on there because, again, sometimes people think, oh, I just pee all the time. It's totally no big deal. And it really usually isn't. However, we can't ignore that bladder cancer, one of the symptoms is an increase in frequency and urgency. So if some simple things don't seem to help it, they really do need to follow up and make sure everything is okay. Bladder dysfunction. This is when we start to have maybe some neurological input, some we call neurogenic bladder, where it just kind of is a little bit out of control. And then poor bladder habits. Again, that going all the time, when you literally train your bladder to go all the time. It's kind of a self-defeating circle. Okay, so how many of you guys regularly ask about bowel bladder function on any level? Excellent. Nice. What do you do with the answers? I know what you do. It's cheating as a pelvic health therapist because most people know what they're coming in for. So when we ask about their bowel bladder, they're like, well, that's a little awkward, but not terribly weird. So in the other settings, what do you do with the information? If they say, yeah, I actually do leak a little bit.
So, well, I'll start. So, this is an area near and dear to my heart. So I work with stroke and brain injury and medically complex patients. And now I'm teaching, but one of the last things I did was to put together a course on this. I mean, so I feel very strongly about that. So we have a psychologist who's got specialty training in incontinence, which is, I think, really rare and a gift at the system that I was at previously. And talking about that and doing a full screen that is consistent with ICF guidelines to look at their participation, and also with using the medical team to look at what could be going on based on those symptoms. That was in an inpatient setting.
Beautiful. And with inpatient, it's kind of nice because you have a team. But again, I think still too much, but not always.
But the team don't think that it's their role,
Exactly.
and nobody is. It's falling between the cracks. You know?
Exactly. So bravo to that system. How about you? If you ask, what do you do with the answer?
It's primarily a screening question for me.
Okay.
And then after that, I'm not always sure what to do with the information, and so that's why I'm here.
Thanks for coming. That's the best setup ever. Some other ways to ask. So one is the screening question was always on our screen is like any recent changes in bowel and bladder habits. So then you're getting bowel and bladder in one fell swoop, and you can ask some follow-up questions. So you said you weren't having any issues, any issues with leakage. You've already opened the door, so you can ask them about laughing, coughing, how many times they get up at night to go, and then you will learn shortly what you can do with that information. You can refer them. So one is to an internist. So this is primarily for frequency and urgency, is to send them to an internist to check for any medical causes. So to rule out a UTI. A lot of people will have symptoms they'll even describe as UTI, but when they do like a dipstick or something that's completely normal. And that's usually when we would come in really handy as pelvic therapists. Perhaps to reevaluate medications, make sure there's not something there that's being a little bit of a problem. And referral for pelvic PT. A urologist or urogynecologist can do further testing, like urodynamics, which if you're not familiar with them, they're kind of intense. You get a lot of information like the activity of the detrusor, the pressure in your abdominal cavity, the sphincter closure, the sensation of the bladder as it starts to fill, as it's partially filled, as it's like filled, and then what happens when you actually release the urine. It's a pretty cool test, but not necessarily one I would ask anyone to undergo if I didn't think it was going to be helpful.
Is that a test that people start with?
No, this is not first line of defense.
Right.
So this is like, all right, so we maybe had you stop having 14 cups of coffee, we're going to have 3 cups of coffee a day. If that doesn't help, maybe we can keep going down this road. So I would never suggest more invasive things without trying the really simple things first. And then for urinary incontinence of any kind, I always say start with the internist. really, if they don't have a UTI and don't have any other risk factors, there's no need to wait to get into a urologist or urogynecologist. There's a lot that can be done in pelvic PT by assessing those muscles, assessing those habits, and then we are perfectly aware after we've assessed those, the people who need maybe more intervention, or we know where to go from there. So this is what a pelvic PT can do. We do understand how to assess the bladder habits. So we learn, most of us get potty trained pretty young, and luckily for most of us it turns out okay. But as we grow up and we get jobs and have kids and do things, we can actually establish some pretty funky patterns that aren't funky because they're our normal. So we can actually have people track for a couple of days and just look how much they're drinking, what they're drinking, when is it, how much is coming out and when are the problems occurring. Because some people won't even realize how many times they're going to the bathroom because it has become that much of a norm for them. And we can also ask more specific questions, not just about their habits, but of their beliefs. If I had a nickel for every patient who said, my mom went through this and I've had 3 kids, so what? This is how it is. But it's not, so you can at least plant that seed, which is really exciting. And we can assess the pelvic floor function. So yes, this is where most people go like, those pelvic people. That's what they do. But we can actually assess the pelvic floor externally and internally with the vaginal erectile exam. And we can assess the function of those muscles just like any other musculoskeletal muscle. So can it contract? Can it relax? How strong is it? How's the endurance? How's the coordination? And really, we are the experts on musculoskeletal systems, so why would we ignore that muscle? And then we would just develop our plan just like any of you would in the clinic to address the deficits we found, be it strength, endurance, coordination, whatever. So we're going to talk about the musculoskeletal bits now. So this is our pelvic floor, and I completely ignored this in gross anatomy. I don't even know if we covered it in gross anatomy. But it's really fun. Is it pointing? Not really pointing. Okay, so the pelvic floor goes from the tailbone all the way to the pubic bone and all the way out to the sides. So it does go around all 3 openings for us ladies. You gents, you obviously don't have the middle opening. So you actually have a little bit more, I guess we could call it integrity in that pelvic floor. All done. But something that a lot of people also don't realize is if we're not dealing with that, how many of you guys see people with hip pain? Nobody? Okay, excellent. How about, well, we'll just go with hip pain. Anyone want to guess what this muscle is?
It's not labeled.
Well, no. I did right. Anybody? Who treats piriformis issues? Yeah, that's a hip muscle there. And so the obturator internus. So this is one of those things where not that every hip or pelvic pain patient or pelvic issue patient needs pelvic floor therapy, but we can't ignore that this guy plays a role in, well, all of our function. So if you're not getting anywhere with the stuff you're doing, it's kind of cool to get someone to assess the pelvic floor and see if there's a way to have that be assessed. Okay, so now the outside view. So we've all passed various degrees of anatomy lessons. So boys and girls are different, but we're still kind of the same. So if we look at the external pelvic floor muscles on a lady, I'm going to point these out. So here's a superficial transverse perineal muscle. Here is the ischiocavernosus, and here is the bulbospongiosus. So the only reason I'm telling you those 3 names is so that you can see on the gentleman picture the same muscles: ischiocavernosus, transverse perineal, bulbospongiosus. So we all have the same muscles, slightly differently arranged. But I think it is important to remember that, in fact, boys have pelvic floors. I've had physicians tell me boys don't have pelvic floors. They do. There's a picture. I know, I'm not sure what they thought was holding all that in, but that was actually the exact words. And I'm not the only one who's heard that. So now we're going to be getting to the sex part, but first we're going to talk about the topic of bowel movements. There is, fecal incontinence is one of those things that it's hard. This is a hard thing for people to deal with. But bowel movements in general, people have similar to potty training for urination, lots of interesting ideas as to what's normal for bowel movements. So some people think if they don't have a bowel movement every day, they're obviously constipated. It's the case for some people, but it's not necessarily everybody's norm. It's normal to have to push really hard to have a bowel movement. In actuality, when everything is working the way it should, you just go in and kind of relax, and stuff should just happen. It shouldn't be a big job. It's normal to have bowel movements that are uncomfortable, and this is not true at all. So it's important to remember, if they're uncomfortable, that's something that can be looked at. Thankfully, most people agree that having fecal incontinence is not normal, and that it's a problem. Unfortunately, a lot of people don't know how to deal with it, or who to go for help. So it can be a very isolating situation that that can impact quality of life. Actually, if you look at the rankings, fecal incontinence impacts quality of life much more than either incontinence or sexual dysfunction. So what is normal? Anything from 1 bowel movement every 3 days to 3 bowel movements in 1 day. Now again, I saw your face. That's not everybody's normal. I'll be honest, if I went 3 days without a bowel movement, I'd be decidedly uncomfortable. That's not my norm. But it is good to know the norms, because I've actually had someone sent to me for, they call it functional constipation, and going over bowel stuff, and pelvic floor is checking out okay. They're like, yeah, but I don't have a bowel movement every day. They're never uncomfortable. They're never had no pain. And there was no way to produce a bowel movement every day for this person. But just because she thought she was supposed to be having it, she was very distressed. So just actually talking about the fact that maybe her normal's once every other day, and that's okay, actually helped a lot. Bowel movements should be preceded by an urge. So if you ever arrive in the bathroom and have a surprise, that is not normal and should probably be looked at. If you lose sensation in your rectum, I get my neuro stuff checked out pretty quick. However, a good friend of mine who teaches an entire weekend course on bowel rehab says we use our rectums as storage containers these days, because it's true. Because what happens is the stool comes down. Here's a quick physiology. The stool comes down, it stretches the rectum, and it says, hey, maybe we can go to the bathroom. And we're like, sorry, way too busy. And our friend who teaches this course, it's like a polite butler. It'll be like, dinner's ready? No? Okay, I'll come back later. That urge will come and go. But eventually they'll be like, fine, you're not going to listen. Well, I'll just go take a nap. So we don't want to use our rectum as a storage facility. It can kind of confuse the urge and make having a bowel movement more difficult. You should have the ability to hold it in until it's time to come out. And then you really should be able to have that bowel movement with minimal pushing. Okay, but has anyone had the experience of working with someone who was incontinent of their stool at some point in their treatment? Yeah, we've all been there. There's a lot of reasons why. I had one, probably the most memorable was like post-colonoscopy. Bless his heart, we were taking a walk. It did not go well. But really, there's a couple of reasons, and asking some simple questions can really get you to perhaps a very simple answer. So one is that poor toileting habits, that just holding it forever and ever and ever and ever, and kind of throwing off your alarm system, basically. So you just kind of quit having that urge to go, and eventually something's going to come out. Decreased tone of the anal sphincters and the pelvic floor. There is some of this that happens as we age. That does not mean you should expect to become fecally incontinent. So these are the times where if it's in the absence of any other neurological findings, it's time to start doing your pelvic floor exercises. And that can be a very simple thing to do. You teach them how to do it, and off they go. This isn't a 3 times a week forever situation. Pelvic floor trauma. So this is more likely happening with the ladies. But during birth, you can have a varying degrees of tears of that perineal area. If it gets back into the anal sphincters, it is unfortunate. Repairing that area is very challenging. However, I've seen several patients for this over the years, and it is possible to regain a good deal of continence, if not complete continence. And then the final, and this is something that any setting that you work in can be beneficial, is stool consistency. Our rectums are not made to hold fluid. So if we do things, so when you're ill, if you've ever had some bad fish or something like that, it's hard to hold in diarrhea because it's not meant to be held in. So that's one thing. However, if it's something that's going on continually, that's something that you might be able to look at with diet, the medications they're on, and looking at how to better manage that consistency. Not that you would necessarily, or that I would even be the one necessarily to make those recommendations, but identifying that as, like, really, I wouldn't expect them to hold in what's coming out of there. We need to look at the consistency and get them to the right person. So ways to ask about bowel function without feeling awkward. If you're dealing with low back or hip stuff, it's not inappropriate at all. I'd say it's never inappropriate, but really, I mean, if we're looking at the muscles and how everything interacts, you can just bring that up and say it's because all those muscles work together. And you can also ask, again, depending on your setting, you can start looking at, you know, like, so I noticed that you never like to have your visit in the morning, how come? And some people, that's how they do their bowel program, and that's awesome that they know that. Other people, it impacts their life negatively to where they don't know when they can leave the house. And so those are things, again, if they're like, are you missing church because you're not sure you can get through? Let's talk about maybe some things that we can do to help. All right, so referrals. So then what do you do with the information? You've asked the question, now what? Again, the internist, just for general screening, especially if it's rather sudden onset, you want to rule out any kind of neurological issues. And then a referral to pelvic PT. Gastroenterologist for further possible functional testing. And again, this is like the urodynamics. This is not something you're like, hey, first thing, go check it out. But there's a lot of different tests that can be done to really test like the transit time, the coordination of the muscles, the puborectalis, is it relaxing, is it not? So they can do a lot more further testing if it doesn't seem to be getting better. On all of these, I put referral to pelvic PT. Yeah.
I keep hearing you talking about the internist being the person to talk to, and I know you talked about that when you were talking about urinary incontinence too. And I'm just kind of wondering about that, if you're talking about considering them referring to the pelvic PT, what have you found to be the level of awareness of these internists about what that PT even have that expertise? Because I have found that they have no clue, and they're not even open to even entertaining it that a PT is actually able to address these issues.
You totally took the words out of my mouth, because that's why I put referral to PT on here, is because you're going to have to, in all likelihood, tell your patient and ask them for a referral to PT. Because a lot of physicians, unfortunately, this is not, well, as we've learned, a lot of physicians aren't trained about what we do at all as physical therapists, let alone, more specifically, pelvic stuff. So I try to educate the patients, because they really do need to be an advocate for themselves. And physicians sometimes listen to patients more than they listen to us.
Yeah.
So definitely I've talked to physicians. I've been lucky and have worked with, when I moved to Chicago, I had a good group of physicians who understood. And so that was easy enough. But yeah, I try to educate the patient, and then if I have a frequent referral source, just try to educate them. There's tons of articles. If you want articles that say, hey, this is what PT does for this stuff, let me know. There's tons of stuff out there that we can. Doctors, maybe they won't read the whole article, but if they read the title, maybe they'll start to reconsider. Because unfortunately, we do still need them to follow up and sign the plan of care and all of that. Okay. So again, what can a pelvic PT help with fecal issues? Can assess those bowel habits. We can look at if there's anything dietary that seems to be. We look at the patterns again. We're not dietitians, but we can look and see if there's anything going on there. We can assess the contraction and relaxation of the pelvic floor. We can assess anal sphincter tone. And then we can actually start to develop a plan to address it. And it really should be, just like any of our plans of care, it should be showing steady improvement in a relatively short amount of time. If you're not seeing some functional changes, you need to talk to the doctor again. Finally, we're going to talk about sex a little bit. So feel free to ask more questions about sex, because I'm a little worried the sex section is going to disappoint you. But we'll see.
Wait, question.
Wait. Oh.
You want to wait on this side?
I have another question.
Yes.
And it's kind of asking your own opinion in terms of like Because now, since I have been pleasantly exposed to women's PT, and I've become a great fan of that, and as somebody who teaches physical therapy examination to PT students, I've been kind of like just kind of considering like, okay, yeah, we will ask, do tell them you should ask those questions about, do you leak, things like that. But in terms of like some of the like the basic tools that, for example, in women's health you use, which ones would you say would be like you'd recommend be incorporated as like regular exams? I know like you guys go into all this stuff even with stools, you assess the shape of the stool and all that kind of stuff, but in terms of like if we're just to give them like just basic tools to incorporate into regular exams.
Mm-hmm. In school, you mean?
Yeah, in screening.
Absolutely. I would say that learning how to explain to a patient how to do a voiding log or bladder diary and how to assess it would be amazing. If we could go into actually physical exams, and I realize that for students that might be an issue doing vaginal rectal exams, but it's a physical exam, so if there's some way that could eventually be worked into primary physical therapy training, that would be amazing. When I was working at the Rehab Institute of Chicago, they were just having physiatrists come in to learn how to do a musculoskeletal exam of the pelvic floor. And it was awesome to see the looks of abject horror and confusion on their faces. But we have to remember it's just muscles. Mm-hmm. And as PTs, if we could figure out a way in our graduate training to do that, it'd be amazing. But I realize there's probably legal issues and stuff. Yeah, lots of stuff.
Oh, you can go first.
Okay.
Oh.
You're the student. Tell us what you think.
So I heard from another student a year above me that she took the women's health course, and they have paid medical models come in that they practice on. They don't practice on each other like any other course, but.
Right. So that would have to be something that would be like arranged and decided.
Right. That's something they do now.
We just had a request that you repeat the questions from the audience just so that we get the louder voice.
All right, so this was just a comment that actually in some PT programs or in some trainings they'll have models come in, so then it's not such an issue, and that would be awesome. That's a great option.
You go first.
You said you have to show progress. How are you most likely showing progress? Is it through the diaries? Are there outcome measures? Are there what are you doing to show them that progress?
Yes.
In a
actually
tangible form.
Actually, I'm going to say no in a moment. So the question was, so how do you measure progress in something like this? And I would say just like everything else we do with function. So if through the diary you're like, well, we have 12 leaks and she goes through 7 pads a day. Now we're down to like 5 pads a day, and she doesn't think she's leaking more than 6 times. Looking at that. For sure. So we look at amount of protection used, number of leaks that they felt, number of voids per day. So like if you're seeing someone who's voiding, did someone void over 24 times a day? She got down to like 10. Yes. So that's the way we do it. And there are some pelvic outcome measures. There's several, like I usually use the ICIQ, which is basically asks, do you ever leak urine? It's them answering. Yeah. But it does give you, it's like, do you leak like 1 to 3 times or like 4 to 7 times? So you can, and then it does give a numerical score at the bottom. So then you can, and I also like, because it is a quality of life thing, and asks about the impact of this on your life. Because some people, I have seen men post-prostatectomy who have 1 pad, are back to all of their activities, and they are still not pleased with it, and that's fair. A lot of people would look at that and say, well, functionally you're doing really well, sir. But that's fair for that to impact their life and us to do something about it. Did you?
Yeah, and I guess I had a question or a comment about finding the subtle questions, because I ask it regularly. Do you have any problem with your bowel or bladder function? If they don't make eye contact, great, then we're going to keep going. And I'm going to keep playing with that. That's kind of how I say, well, I'm a spine specialist. This is in the same zone, and it's the no man's land from nipple line to nuts for guys. That's what I say, and they're like, yeah! And then you just talk regular.
Yeah.
But, like when they don't want to talk, it would be like, that. There you go. Or, not great. But like, killing me today. But I think some of the subtle stuff is like the behavior stuff you're talking about, And like I've had people who've had fecal incontinence, but they don't see it as fecal incontinence. Well, yeah, I guess, and I didn't want to. Wait, you know, that's not your fecal matter necessarily, but it's that highway. You know, you didn't want it, and it did, and you're at church in the middle of mass, and yikes, you know.
Yeah, and that so like if you if something happens, you can sometimes maybe mention it, like, did you mean for that to happen? Or if they say, oh yeah, that happens, and that's just whatever. I usually bring, well, did you know there's something you can do about it?
Right.
And sometimes they're like, I don't care. I don't really care if I fart in church. Okay, if you don't care, I don't care either. Unless it's a sign, unless I think it's a bigger sign.
Right.
But if really for them, it needs to matter to them. And if they really don't want to, again, at least you planted that seed of like, hey, maybe this does bug me. I can do something about it.
Yeah, and I guess that's the part of like, again, for all the women, and I see a lot of women have post-menopause who are like, well, yeah, my gynecologist says this is normal. I'm supposed to always read. What? What? And I said, and you're okay with that? If really you're okay with that, you know.
I would usually say I actually would respectfully disagree with your doctor because there's actually a lot you can do. So if you're happy with how you're managing it, yay. If you are interested in learning some more, let me know. And then I can just bring it up. Now back to the manual muscle testing. I have had people with 0 out of 5 pelvic floor have no incontinence at all, and I've had 5 out of 5 leak.
I have no idea how you measure this. I
The
am.
finger.
So ask your friends who took the course. But it's just like manual muscle testing, anything else. It's basically just palpation and a squeeze and lift. But strength and function don't necessarily correlate. However, they should, if they're neurologically intact, be able to contract and relax when they say contract and relax. So that's the biggest thing I look at. And then we start looking at all the other factors that could be contributing. And Sandy, did you have a question?
No, I was going to make sure you got back to that correlation.
Okay. Anything else about bowel and bladder?
Well, I just want to go ahead, Sarah.
Go ahead.
Okay, so but I just wanted to say that just as independent practitioners of choice in the future, and even now with population health being something that's growing at a rapid rate, if they saw their physician at all, if that physician really did a thorough screening, and if that physician even understands or asked that question and got an honest answer. I was just reviewing a case on MS where one of the first signs is often bowel, bladder, and sexual dysfunction, and if they're uncomfortable bringing it up, they're not going to tell their doctor. And to your point, Sarah, they might talk to the physical therapist because as we work with them, we can continue to ask that question as we pepper it in while we're working with them and we have that trust established. But we're supposed to do medical screening to make sure that if we're supposed to refer out, we could be screening for cancer or endocrine disease or gastrointestinal issues. And we're looking for that while we're treating that musculoskeletal because we know that that can refer to the shoulder, to the spine, to the back, to the head. So I also just think it's something that as just good practitioners of choice to help the whole world catch up with us, that just needs to be part of our basic screening where we get really, really good at asking in different ways throughout because people aren't comfortable, but we got to get comfortable with it.
Exactly, and hopefully there's at least a couple of different things in here that have kind of made it like, okay, maybe I could bring it up, but also, and I have a slide at the end, where to reflect on what makes me feel so awkward about asking this person about sex and kind of work on that end of it, because again, they are likely looking at you as a medical professional, and if you ask the question, hopefully they will answer. You know, they're going to hopefully understand you're asking for a reason as a medical professional, and it's not just being nosy. It's something that we need to know. So yeah. Okay, sex, finally. So, sexuality, did I make all those blue marks? I'm sorry. Sexuality is complex. It's not an easy thing to understand. There's a lot of things that go into it, and there are people who are experts at this. But I think as humans, we're quite aware that we have issues with sex can arise, and they can be coming from a lot of different areas. So there's emotional issues, the maybe not getting along with your partner, the not being sure how you feel about turning, 30 or 40 or 70. Social factors, what other people are thinking, how you're interacting with the outside world. Isolation. So again, a lot of times, if you're very ill or disabled and you're in a situation, then it's much more difficult to be social. That could be a challenge. Psychological. So that includes psychiatric. So depression, anxiety play into this a lot. But then also psychological experiences you've had, things you were told when you were growing up, stuff you saw when you didn't need to see it. All of that plays in. We're going to be talking a little bit more about the physical. So things, when everything's working well, everything's working well. But if something else goes askew, sometimes the physical doesn't work as well as it did for men or for the ladies. But then also physical is we work with people with varying degrees of disability. So what about that? I had this great patient who had CP. We had to work on positions that wouldn't set up for tone. So she was married, happily married, enjoyed sex a lot, but was developing some serious tone issues. So the physical issues people are having, we're again those experts, and we could be very helpful in just situations like that. Aging, stuff changes as you age. Hormone levels change, physical ability changes as you age, maybe. And then also religious things. So, and religious and cultural maybe can be smushed in close together. But again, what's accepted in your community can impact how you feel about yourself on a sexual level. Okay, so ladies first, what's normal? I like to say, yeah, what's normal? The spectrum of sexuality is a spectrum. And so it's really not necessary to be like, oh, that's weird, or, well, that's really cool. It is what it is, but what's not normal is any pain during sex. And a lot of people will ask the pain question about sex, like, well, about S&M. If you like it, it's officially not pain. So if someone says, it hurts when this happens, it hurts when this happens, and we can take a look at that. It's never normal to really have pain after an orgasm. So sometimes maybe sex is okay, but they develop discomfort later on. That's something that can be addressed. And really anything at all. So leg position, I get pain in my back. My hip hurts when we're done. Those are all things that can be addressed by us, actually. And for the gentlemen. So for the gents, there's a lot more external stuff going on. Erectile dysfunction, it's on the television now all the time, so it's a little bit more talked about. But really what it means is achieving and maintaining a functional erection. And they consider functional having it stay erect enough for penetration. That's kind of the guidelines for that. There's a lot of factors that go into a man's erection. I never thought I would say that in a talk. But the pelvic floor muscles do play a role. So pelvic floor muscles for men need to contract and relax and be functioning well and be healthy with good blood flow for this to happen. Some things that might really impact it, treatment for cancer. So both radiation, which can change the tissues and the health of the tissue, as well as prostatectomy, that's going to perhaps create some nerve issues. Now the prostate's gone, there's a lot of stuff that changes when that happens. Those are things that will, in all likelihood, lead to some degree of dysfunction there. But also, I consider pain during orgasm or post-orgasm, this is a sexual dysfunction for men. If it hurts every time that happens, how much do you want that to happen again? Not really. So that is something that can be addressed, and it is frequently pelvic floor dysfunction, just kind of a hiccup in the system where it's no longer contracting and relaxing the way we would like. And then decreased sex drive. Again, many potential factors. It's actually, I should put that on the ladies as well. But depression, anxiety can kill the libido. So if the libido isn't there, it's a little bit more challenging for the erection to be there. All right, so possible physical causes, because we're physical therapists. Some of the physical issues could be pelvic floor trauma or dysfunction. So we've already talked a little bit about the dysfunction part. Trauma, typically, I would say due to childbirth, but we have also really weird accidents. So, but anytime that pelvic musculature is injured, that can create a problem. This is physical, it's physiological. Decreased estrogen in the female, so it can be seen with birth control pills. during menopause and postpartum, especially if women are breastfeeding. So every now and then I'll have patients who are like, God, this part just isn't getting better. And when we talk about exactly what they're experiencing, we're like, all right, how much longer are you going to breastfeed? Because I would bet you a nickel it's probably going to get better. Everything else checks out fine. And once the hormones level out, it can just get better on its own. But again, knowing that it'll get better, or knowing that it can get better, is huge, getting the weight off of their brain. Decreased testosterone in men. So that's a situation, again, it can happen as men age. I've not seen so many commercials for it, but there was the low T meds for a while. They sound terrifying. But yeah, so there's ways to help manage it, but it is something that a doctor would want to address. Prostate issues, so not just prostate cancer, but when the prostate enlarges, that can create some issues, as well as prostatitis, which I always say with a little bit of an eye roll. A lot of pain issues and a lot of male issues tend to just be labeled as prostatitis. I would encourage, if you have a patient who says they're having issues, especially when there's discomfort involved, and they've been diagnosed with prostatitis and have done their antibiotics, to ask their doctor, bless you, for maybe a script of physical therapy. Because if it was prostatitis and it was infectious, then antibiotics should have done the trick. Pelvic pain or anticipation of pain. Both Sandy and I have seen a lot of people in our clinic where it's not even that it hurts. My patient was a female. It's not that penetration hurt, it's that it freaked her out and she thought it was going to hurt. And once we kind of just talked her through that and did kind of some general desensitization, education stuff, it got so much better. And then other orthopedic issues. I like to point this out because if someone says they're not having sex anymore, and it's because, well, the doctor told them they couldn't move their spine from their spine surgery that they had 8 months ago, that's time to have a chat with them, make sure they're done with those precautions and there's no other reason why they should be following them, and sometimes they just need to know it's okay. But a lot of post-op, I just had a nice chat with a person on Twitter. A person had a laminectomy, wanted to get back to having sex. Was still having some radicular symptoms, was still on her lifting restrictions of not more than, I think, 10 pounds. And what else? Oh, she was an extension responder. I said, excellent. If her doctor clears her to do the movement, I would say on top would be the best for her. But what we would need to know is if that's okay for her arms, whatever that lifting limit is. The doctor said, any position that she's passive and doesn't move would be great. And all I said was, functionally, that makes absolutely no sense, because at worst her knees are going to be bent and she's already into lumbar flexion, and she wasn't supposed to be. The doctor did not think it through. So sometimes we need to be the functional experts, and I realize talking sex positions might be a little bit awkward, but I can guarantee it will also be funny. And so asking about sex might seem way out of line. At work, we're not really encouraged to discuss sex very much. But if you use the initial oswestry, it's on there for you. A lot of oswestry scales have taken that question 8 off, but it's there. If it's there, then the question's there and we're all set. But if it's not, just listen to your patients. Like you said, we get to know them. They start talking about their families, this and that. It might come up. And then, again, as long as you always ask with kindness and respect, I mean, you are asking a personal question, so it's fair to maybe say this is going to seem awfully personal, but this is why I would like to ask the question. And be ready for a few follow-up questions if they bring it up. So again, there's orthopedic issues that may be preventing your patients from getting back to or beginning to have sex. And it could be a very simple answer like, well, why don't we check with your doctor about those post-op restrictions? You shouldn't even be on them anymore. And don't make assumptions about marital status or sexual preference. So if you're going to go down this road, don't go like, so how's sex with your husband? When, well, they're a lesbian. Or they're, I mean, it's just one of those things where we try to ask just, are you sexually active? And if they say no, would you like to be? And kind of go from there, because sometimes it's just lack of opportunity. Not quite. Because then if the answer's no, and that is on Facebook.
Classic.
I was waiting for that to happen. But if you ask, you know, like, is it lack of opportunity, lack of desire? Like what's, if you would like to and you're not, what's the limitation? Because sometimes, I mean, I wouldn't suggest you be a dating service, but yeah, but finding out what their limitation is, their limitation may be something that's appropriate for us to help address. Okay, potential referrals for sexual dysfunction is a much longer list because there's a lot of different things that it could be. Again, you are going to be able to, in all likelihood, narrow this down for them because you've been talking to them. So for females, you know, an OB-GYN or a urogynecologist to discuss any female problems that may be going on. Gentlemen, a urologist would be probably the best first stop. Physiatrist, I put that on there because there are physiatrists who are in like women's health teams, pelvic health teams, who are quite aware, who are able to go like, okay, so we know it's not cancer, we know it's not this, let's take a look at those muscles, you need to go to PT. And they're also much more well-versed in what we do have to offer, and most of them are a little bit more open to the idea. Couples counseling. Most of the time, sex has at least more than one person involved. So sometimes it's that relationship, and we're not relationship counselors in a lot of ways. So do that sex therapist can go through all of those other psychological things, the relationship things, they can come in handy a lot of different ways. Sometimes just go back to their psychologist. Ironically, depression and anxiety can decrease your libido. Guess what a lot of the meds for anxiety and depression do? Lower your libido. Some people are kind of okay with that, like they feel better mentally, so they're kind of okay with the trade-off. Some people it's very distressing. So it's not about making everyone want to have sex, it's really about, is it bothering you that this is a situation for you, and helping them identify a way to help that. And then, pelvic PT. And we can come in very handy. Okay, so this is just kind of a general thing because so many people for so much of my career just called me like, she's just a women's health therapist. I do the entire body. Some people call it just, it's orthopedics in a cave. That's all we're doing down there. So we can assess those pelvic floor muscles just like we do for anywhere else. We can identify more specifically the tissue dysfunction that may be creating the pain. Best example I can think of that is after delivering a baby vaginally, sometimes there's a little bit of tearing, and then we stitch that up. Just like a scar anywhere else on our body, it could become a little bit sticky, a little bit tight, a little bit sensitive, and what do we have people do with that? Well, we touch it, and we mobilize it, and we maybe desensitize it a bit. It's weird when it's down there, it's scary when it's down there, and sometimes that's all we do is educate them regarding that. But if we can actually touch the spot and say, this is the spot that bothers you during intercourse, bam, we know the answer, they know the answer, it all of a sudden became less scary. We can develop a program to address the issues, and then honestly, this is one of my favorite parts of my job is the identifying of sexual positions that can help minimize pain, decrease the exacerbation of symptoms, and kind of even have that recovery plan. Because if someone really loves to go run marathons, there's going to be recovery periods, maybe some aches and pains. If that's happening after intercourse, we're like their recovery team. So there's a lot that we can do to help. All right, possible barriers. So again, the biggest one is just being uncomfortable asking the questions. So if it's hip, pelvic, and low back issues, it's not inappropriate to ask. So think on that. If you ask a question, and we talked about this, if you ask a question that the patient obviously does not want to answer, you don't have to push them into it. If they don't want to deal with it right then, if we're not thinking it's another medical situation that really we need to investigate more, okay, we planted the seed, we'll see if it grows. And patient embarrassment or shame. However, kindness and education go a really long way to let them know that it's not okay that it's happening to them, that really there is help, and sometimes just that can get them to open up a little bit more. So now what? So this is my challenge, because I think Sandy's, well, both of you are pelvic health therapists now. So now what? I challenge you to educate your clients that there is help for these bowel, bladder, and sexual issues. If they mention it to you, don't do it like, not my department. Really, you can help them find someone. And if you're like, excellent job, Sarah, I don't know who to find, let me know. We have a great network to the section of women's health, and actually in the Chicagoland area, there's hundreds of us. So if you want one, you let me know. I challenge you to reflect on why you may not be comfortable asking or answering the questions regarding these issues. If really, like, why don't I answer those? And you just feel super weird about it, reflect on that. Again, I'd be happy to talk to you about it. It's gotten so not weird for me. Sometimes Sandy has to check me when we're out in public. But I also challenge you to not ignore that your patients may be dealing with this in silence, and that it really truly is a huge impact on their quality of life. And so if you can get to them, you can work on finding an approach that really can change. I mean, that's what we're here for, is their quality of life. We might be able to help in that way. There we go. I don't even know how long that took.
Exactly an hour. You're very good.
Stop it, really?
Really. So
Alright.
I guess if anyone has more questions, you can just kind of open up the floor.
Okay.
I have a comment, because I've just been thinking a lot about this in terms of, for example, when therapists work in acute care, that, sometimes, as, this occurred to me that this can actually hinder their patient's ability to attain their functional goals. Just, for example, if you have even a normal patient who just, when they go from sit to stand, they leak. Because of that, you may be trying to work on transfers and stuff, and they don't want to, they're reluctant, and it's not even anything to do with the fact that they're physically not able to, it's just a concern that when they stand, it may leak. And I think sometimes those are some of the things that we don't really kind of think about, but if we begin to really think more holistically with our patients, I think it will be.
Yeah. When I first came to the city, and I was working in a hospital, and I was actually invited to be on a continence task force. I'm like, that sounds great. I can't wait. What was horrifying is that the continence task force was formed because patients were leaving the hospital incontinent when they were coming in continent. So sometimes what it is that you end up in a situation where you're not allowed to go to the bathroom, or you're told just use the diaper, that's fine. And then actually they were leaving lower level function. And when we think about if someone's leaving the hospital, hopefully they're going home. But managing continence at home, or managing incontinence at home, can be a deciding factor. Like, oof, if they were continent, I could bring mom home. But since she's not, maybe she goes to the sniff for a while. So really, continence levels is huge.
I sort of have a question, sort of piggyback on that. Sometimes in the hospital we'll do a good job of getting them continent, but there's some management, as far as the person assisting that person in the toilet.
Yes.
You know what I mean?
Yes.
So they are continent, but they might need help cleaning and stuff like that. And sometimes caregivers might say, well, we'll just put the diaper on and I'll clean up afterwards, but to get to the restroom back and forth, is there any education that we could give them that, says the amount of time that you go and let this happen, it's going to get worse or it's going to be harder to recover from? So I think sometimes they think, oh, she'll be better or he'll be better in a couple months, and then he can take care of it, she can take care of it himself. We'll just wear the diapers until that time comes.
Yeah, I'd say it's really important that if we have the ability to use the bathroom, we use the bathroom. And if it's more that, like, okay, so getting to the bathroom is okay, it's more the cleanup that's an issue, I would look at what can we do on that end. So what is the problem with the patient or the person who needs care? Why can't they take care of their own business? Are there some aids that we can get there that would make them a little more independent? So that wouldn't be such an issue. But yeah, I think just looking at the individual situations and figuring out what's the barrier. So, okay, great, they're getting to the bathroom, that's good. Oops, they can't get to the bathroom, bedside commode. And kind of working that way. Because again, we do toilet transfers as part of what we do. We work on mobility, getting them from here to there. Really, it's kind of mobility. So what's the limitation? And again, stressing the importance to caregivers that it's really not okay, especially if that person is cognitively intact. That's an awful situation to be in.
Well, can to that? Because I think you touched on that there's different treatments, so like time voiding and working with that caregiver on how can they plan so that the patient and the caregiver are part of that discussion together might help with that, right? Because if they can decide where, if the caregiver's more comfortable having the person lay down, they can do timing. Right?
Yeah.
And that might be a halfway strategy.
Yeah, that would be like a really fun like brain teaser to have like when you run into those situations. Because there really shouldn't be any need for someone who doesn't need a diaper to become accustomed to using a diaper.
Now, what age? Oh, one second, we have a question. Do you have recommendations for applying for a women's health residency? And also, do you have any suggestions for level 1 pelvic floor courses? This is for a person in the central Illinois region. So if you don't know, we can research.
Yeah, for the residencies, I'm afraid I don't have tons of answers. I know there aren't very many over the country. So I would say find the ones that you'd like to go to, apply, and have a plan B. But then also, so for a good level 1 course, there is the section on women's health that comes around to different areas of the country. Herman and Wallace is another organization. I don't believe, missing Sandy. Those are the 2 biggest ones for basic pelvic floor training.
I know Evidence in Motion just
They're
started the
just
pelvic floor certification, and it's nice because it's a hybrid. It's a distance learning format, so you'll have, it's available in any area of the country,
Right.
where you have some distant learning, online learning, and then you have some on-site weekend intensive training as well. So
Right, and
Evidence
that
in
just
Motion,
started
and that
though.
just started.
If that's brand new, and I'm not terribly, I know Evidence in Motion, but I'm not familiar how they set it up or who's teaching it or anything like that.
What?
Okay.
What age could I send somebody? How young?
There are pediatric therapists, and Sandy does some with pediatrics. I personally don't do much. That's again, if you have someone that you're thinking maybe could benefit, I'll give you my business card because we have some.
And I've had a doctor call, and we just referred out. But I don't know that I've referred to anybody specific. We just referred to a site that's local.
Yeah, and there's it's one of those things. So we're part of the Chicagoland Pelvic Floor Research Consortium. And so it's much bigger than just Chicago. So usually an email out to them, you'll find somebody. So I can give you that contact information. That'd be helpful.
That's where I assume somebody that.
Any other questions?
So if somebody wants to go this journey of being certified, heading towards that, ultimately taking the women's clinical specialist certificate, can you just share a little bit on the journey, like what's the process?
So it's been a couple years since I went through that process. I can say that I don't remember how many hours they require, but they require, I believe it's close to 500 hours of women's health treatment. So you would need to have an opportunity to actually have a pelvic health, even though they only test around the women's bits, caseload, and hopefully where a mentor could help you out. So you need just the clinical experience, but then also I personally went through the sexual women's health courses, but a lot of people have gone through other avenues to get the kind of the didactic as well as the manual examination skills, and then get a good study group. Because then it's just a lot of article reading, a lot of studying, and then you have to pay to take the test. It might be the most painful part. But it's overall it was a journey that where I was working. It was a fairly easy decision to make because I had almost all of a sudden 100% relatively complicated pelvic health caseload with a whole bunch of other women who were doing the same thing at the same time. So I can tell you that having the support of other people around you, and I think that's the case for any other CS as well when you're studying, to find a group either online or locally to get in. But then anytime you want to talk pelvic health, you can just call me because I obviously like to talk about it. Does that help at all?
Yeah, yeah.
Any other questions? Okay.
Thanks, Sarah.
Thanks.